Okay. Um, in summary, management of VT storm, I will present a case of VT storm, but I'd like first to what are the definition of VT storm. In patient without implantable ICD, electrical storm defined as occurrence of two or more hemodynamically stable ventricular tachycardia within 24 hours. And with patient with ICD, the most widely accepted definition is three or more appropriate therapy for ventricular tachyarrhythmia, including both shocks and antitachycardia pacing. So it's not only the shock for VT that we consider is as a high risk and VT storm. If the patient had 4 or 5 VT in 24 hours and treated successfully by ATP, it's also considered as a VT storm. This is the only thing that I'd like to share. My case is interesting case about patient with non-ischemic cardiomyopathy, 62. His history starting 9 years ago by anterior STEMI, successful perfusion, and last ejection fraction was 35. CRTD was implanted 2 years earlier than the VT ablation for the first attack of VT. So the first attack of VT come after 7 years of myocardial infarction. It's only one, and he was in left bundle branch block. So I implant for him a CRTD for first episode VT. Ejection fraction did not improve, although CRT was in a good place because it is ischemic cardiomyopathy. 2 months before presentation, recurrent VT and ICD shock despite optimum antiarrhythmic and antifailure treatment. And 1 month before ablation, he was admitted to different hospital due to VT storm. So ablation arranged under general anesthesia using the 3D CAR2 system. The plan was first substrate mapping, because when I saw the ICD recording of the device, it was Medtronic, I could see most of the VT had the same cycle length. So I was hoping that there is only one VT that share all these ATP and shock. So I get into under general anesthesia, but unfortunately, when I was using the Pentaray, different VT was inducible by catheter manipulation, and already multiple DC shock was necessary to restore hemodynamic status. Actually, I count all the VT. More than 12 different VT was recording. I will show all of us, to you the 12 different VT that exit either from the anteroseptal edge or anterolateral edge or inferior edge. As you can see, the first one was the clinical. By the way, it is not hemodynamic compromised VT in the clinical. It was cycle length about 420. And as you can see, all these VT have inferior axis. Inferior axis, so it is from the anterior wall, and as you can see, it is also have V1 to V6 almost positive concordance, so it is a basal anterior exit. But as you can see, V1, VT1, VT2, VT3 have different morphology. One is slow, one fast, but all of them sharing inferior axis and basal location. Also, VT4 and 5 is narrow VT with septal exit. V6 and V7 also septal exit by a different exit. And these another 4 VT different VT with in superior axis. Superior axis that they are rising from the inferior edge of the scar. So uh, I record all the map. Lead potential were found in every place. As you can see here, the 3D image of the voltage map of the patient. It was a nice map actually. Um, Record lead potential in every edge of the scar. So in every edge of the scar, I was doing a carto match for the clinical VT. As you can see here, there is a basing in the first ECG, and it matches the clinical VT about 96%, and also 98% carto match for another VT. In everything, in every lead potential that match the VT, I'm burning that lead potential. And finally, I almost ablate in every edge of the patient. It's ablation at septal edge and ablation at the lateral edge and even ablation of the inferior edge. Almost what is called that I surround all the edges of the scar. And I was happy because I think I did my best. And uh, um, after induction protocol, after all these four hours of work, still there is inducible VT. And even endocardial activation map for such VT show an early at the inferior edge, but ablation at such edge did not terminate the tachycardia. So I guess that there is another isthmuses in the even in mid myocardium of the epicardium. So after 4 hours of work, I go to the epicardial space and map, do a voltage map for the epicardium. And also I found a lead potential in the epicardium, as you can see in the ECG, that there is also lead potential in the epicardium. About 1 hour of ablating in the epicardium, all the potential, I found that there is no any VT inducible, and this is the last one that I ablate. I got a very nice 12 of 12 base match from the epicardium, and this is the lead potential which I could capture. And after 6 hours of endo-EPA mapping, we succeeded to render all VT, all about 13 non-inducible. When the patient go to the CCU, after 48 hours, the patient entered into insistent VT. For strange, another new VT. And this insistent VT cannot respond to DC shock or even aggressive ATP. So the patient we kept on IV amiodarone. The VT was about heart rate 120, so it is the patient is still hemodynamically stable. And I entered for the second time to do activation map for such a VT. It is a new VT. It arises from almost apical inferior edge of the scar. Although they have a Slater chaos complex which suggests epicardial origin, I did first endocardial map for an endocardial activation map, and the endocardial activation map get a hot point. It is not that much pre-chaos complex, but even ablating in the hot point did not terminate the tachycardia, so I entered the epicardium for the second time, and for the second time, it is also the epicardial activation map, a lot of hot area. At this hot area, the chaos complex is not that much preceding the chaos complex, and even entrainment technique shows that a very long BPI minus tachycardia cycle in. So I did know that the endocardial exit or the endocardial hot point and the epicardial hot point is not the true isthmus of such tachycardia. But where is the true isthmus? After activation map in the endocardium and the epicardium. So these suggest an intramural isthmus that had been embedded inside the dense scar, and I should search for this protected isthmus in the intramural. So I revised my map and activation map, and even got another bent array to search for any diastolic potential. And I was lucky that I got a diastolic potential inside the anterior edge, anteroseptal edge of the scar. At such point, just pushing the ablation did stop the non-stoppable tachycardia. The tachycardia was already 3 days long, was non-stop. Just pushing the ablation catheter at this potential did stop the tachycardia. And as you can see, this is the diastolic potential in the dense scar. Ablation at such area already give me the 12 of 12 tachycardia morphology. And here is the ablation point, just one ablation point. This is the exit site, and this is the successful ablation point. You can see how far away it is from the exit. I guess this is the protected isthmus, is the inlet of the protected isthmus as the anterior edge. Non-inducibility was achieved with very aggressive protocol and follow-up 4 days in the hospital and 6 months after no any other VT. This patient had a VT stone, and I found why he had a VT stone, because he had a very large scar and very multiple isthmus indeed. Thank you so much.
Thank you very much. This is an interesting, very difficult case. You were very courageous to go twice endo-epi within days, but this is the life of a patient.
Yes, that's true.
Was there a role of the intramyocardial needle ablation that Stevenson to go into the intramyocardial, or using other concentration of the saline in order to go into you said there was intramyocardial scar, right?
Intramyocardial isthmus. But ablation at the exit extensively by about 55 watt endocardial and about 40 watt epicardial did not reach this isthmus. So this only filament in such scar. It's only one filament that makes these. So the challenge is, where is this filament? I found its inlet at the anterior edge of the scar, at the anteroseptal edge of the scar. And here is where I could ablate the tachycardia. The challenge here is, where is this intramural scar?
دكتور جون، ريجاردنج الكيس اللي حضرتك عرضتها، الهيموداينامكس بتاعت البيشنت كان اخبارها ايه؟ هل حضرتك بتحب تبدا من الاول باكمو ولا لا؟ البيشنت سكار، لارج سكار، مالتيبل ابليشن ات مالتيبل اسماس، راي حضرتك ايه؟ اكمو فروم ذا ستارت.
الإكمو is important thing if you have already hemodynamic compromised. But I was lucky that the patient, the first procedure, he was in sinus spasm, and our anesthesia team was very good stuff. That even in 6-hour procedure with different inducible VT and different shocks for the patient, we are lucky that we end the procedure with no complication. Even in the second procedure, although he entered the cath lab with VT at a heart rate 120, his blood pressure is maintained. So in such case, I didn't use the ECMO. But if the second procedure insistent VT have a low blood pressure on inotrope, I guess we can use an ECMO definitely. Mm.